Today we're going to discuss polyhydramnios. This is a subject that I consider one of the most diverse and confusing of the entities that we must deal with in obstetrical sonography. As you know, variations in the quantity of amniotic fluid are not terribly uncommon, and this is certainly an entity that you will have to deal with several times during the course of a year. It's sufficiently confusing that the following is my favorite quote. Bevis was a physician who was one of the pioneers of amniocentesis, and he said this about the amniotic fluid. "We know very little about the production and disposal of the liquor amnii." He was a Brit. "The only sure fact is that in this country nearly 2,000 tons go down the drain every year." Well, that might be a very clever statement, but in fact, quite a bit is actually known about amniotic fluid. I'm going to boil this down into its simplest components. Amniotic fluid behaves as a separate compartment within the pregnancy. The fetus will influence the amniotic fluid, and the mother will influence the amniotic fluid. But these are the facts that I try to keep in mind when I'm analyzing an aberration in amniotic fluid. After 16 weeks, virtually every drop of amniotic fluid comes from fetal urination. You should think of the fetal kidneys as the pre-processing plant for amniotic fluid. After it is produced, the amniotic fluid is swallowed by the fetus and then reabsorbed in the small bowel. So you can think of the small bowel as the post-processing unit. So anything that interferes with the production or absorption will alter the amniotic fluid volume. There will be times when polyhydramnios makes sense. So here we see a fetus with the double bubble sign. This happens to be the stomach. This happens to be the duodenum. I want to caution you that not all double bubbles are caused by a dilated duodenum and stomach. There are several other double bubbles that occur in the upper fetal abdomen. So be cautious that when you are about to say that this is secondary to a duodenal obstruction, that you actually document that the stomach communicates through the pyloric canal with the structure you are calling the dilated duodenum, or the second of the double bubbles. Note that when the duodenum is actually obstructed, the stomach is working against an obstruction, and therefore you will often see hypertrophy of the gastric wall as well. Here is a confusing origin of polyhydramnios. You might even think, well, here's a double bubble as well, but this particular double bubble is bilateral UPJ obstruction. So when we think about bilateral obstructions of the fetal urinary tract, we think about oligohydramnios, and yet bilateral UPJ obstruction is far more likely to be associated with polyhydramnios than it is with oligohydramnios. I spent about 2 decades thinking about why that should be so, and I have to tell you that I don't have a clue. I don't know why bilateral UPJ obstruction should cause polyhydramnios, but without question, it definitely does. So when we're thinking about polyhydramnios, we must have a very broad concept of what might be going on. I'll touch on this to a greater degree later in the lecture. So, there are abnormalities where it makes sense that the fetus should have polyhydramnios. So, a fetus with a central nervous system anomaly, that anomaly may interfere with the swallowing mechanism, resulting in inadequate swallowing and therefore inadequate reabsorption of fluid in the intestinal tract. Gastrointestinal tract obstructions, just as we discussed a moment ago, if the gastrointestinal tract is obstructed, then the likelihood that fluid will be normally reabsorbed in the small bowel greatly diminishes, and polyhydramnios likely will ensue. Certain varieties of neuromuscular disorders, these also can significantly interfere with swallowing, resulting in polyhydramnios. Then there are a variety of conditions that are known to be associated with increased perfusion through the fetus. The most important of these are the twin-to-twin transfusion syndrome and large teratomas. Under this circumstance, where increased perfusion results in polyhydramnios, we have increased perfusion throughout the fetus, which means we have increased blood flow to the kidneys. Increased blood flow to the kidneys results in increased urine output. Increased urine output can result in polyhydramnios. The reason that we're interested in polyhydramnios is that it results in increased perinatal morbidity and mortality. Now, perinatologists are always looking to try to identify high-risk groups. This is their bread and butter. Perinatologists deal with high-risk pregnancies. And here is a typical example of a high-risk pregnancy. Polyhydramnios increases perinatal morbidity and mortality. Now, if I were to ask you to list the 3 features which increase the likelihood of a poor outcome with polyhydramnios, I'm sure that after a very short time of reflection, you would come up with the right answer. So you would say, more oligohydramnios is worse than less oligohydramnios. True. If it starts early in pregnancy rather than late in pregnancy, it's probably going to have an increasingly poor prognosis. True. And that the faster it came on, the more likely it would have a poor prognosis. Also true. So these 3 factors, easily thought through using simple logic, tell you who is more likely to have a bad outcome. Now, if we actually look at the definition of polyhydramnios, we find it's greater than 1,500 cc's of amniotic fluid at or near term. This is useless to us for a variety of reasons. As sonologists, we can't use a static definition of at term. We're obligated to make judgments about amniotic fluid volume throughout pregnancy. We can't wait till 40 weeks to make a decision as to whether or not what we're looking at is polyhydramnios. As well, we have absolutely no way of actually predicting how many cc's of amniotic fluid are in the amniotic sac. We can only estimate it. Indeed, we can see among these 105 fetuses that we studied with polyhydramnios, and I will refer back to this study in a number of slides during this lecture, you can see that in fact, you can see polyhydramnios from the beginning of the 2nd trimester all the way through the end of the 3rd trimester. Now, these were the earliest sonograms at which polyhydramnios was diagnosed. Therefore, someone in this group may have actually occurred at this time, but a sonogram wasn't done at that time during pregnancy. Nonetheless, you can appreciate that the time that polyhydramnios is most likely to be seen is at the end of the second trimester and running through the bulk of the third trimester. This is when we tend to see it most commonly. Now, as we said, the static definition of 1500 cc's is useless to us. So, it's a rather remarkable statement that I'm about to make. But if you want to know what polyhydramnios is, it is what you say it is. So when you pick up the dictaphone and the word polyhydramnios comes out of your mouth, all of a sudden, this is a case with polyhydramnios. Now, hopefully, you weren't sitting there bored that day and thought to yourself, you know, I haven't said the word polyhydramnios in quite a while, so I think I'll dictate that in this particular report. Obviously, there's something about the look or the measurements of the amniotic fluid that made you suspect that this was a case of polyhydramnios. And in fact, there are 3 mechanisms that have been described for the sonographic diagnosis of polyhydramnios. We are going to start with the second one on my list, which is called the 8-centimeter rule. Now, this was a rule that was originally described in a paper by Chamberlain and Manning. Now, Frank Manning is a very well-known maternal fetal medicine specialist and ultrasound specialist who worked this out, where he said you measure the deepest vertical pocket of fluid that you can identify, and if it's 8 centimeters or more, that constitutes polyhydramnios. Well, to be perfectly honest, even though I have a great deal of respect for Dr. Manning, when I read his paper, I thought to myself, Frank has gone off the deep end here. There's absolutely no way this complicated fluid that we see insinuating here and around this structure and around that structure, take one measurement and you can decide whether there is or is not polyhydramnios, made absolutely no sense to me. However, I will admit, he did a study on a large number of patients, well over 7,000 patients, and using the criterion of 8 centimeters, 243 of them, or 3%, turned out to have polyhydramnios. Now, in medicine, as you know, normalcy is usually described by plus or minus 2 standard deviations. Well, 2 standard deviations on either end of a bell-shaped curve excludes 2.5% of the patients. 95% of patients are contained within 2 standard deviations. So 2.5% and 3% were really pretty close, and I certainly could understand his desire not to make it the 7.85 centimeter rule or the 8.21 centimeter rule. Those would not make sense, and a nice round number was the most appropriate thing to recommend. Well, as I said, I thought that Dr. Manning had definitely gone off the deep end, and Dr. Ruth Goldstein and I decided we were going to prove that he was wrong and publish our results. So we were big believers in the visual estimate of amniotic fluid. So we did the following study. We took a large number of patients where we looked at our visual estimate of amniotic fluid. Now, when we did our visual estimate of amniotic fluid, we allowed ourselves to say it was oligohydramnios or polyhydramnios. By the way, Chamberlain and Manning also described the so-called 2-centimeter rule for oligohydramnios, so they were the originators of both the 8 and the 2-centimeter rule. So, We either scored them visually as oligohydramnios or polyhydramnios, or normal. But in the normal group, we allowed ourselves to say it was normal but below average, or normal but above average. Then, 3 months later, we came back. We had large field of view images of the entire uterus, and we measured the single deepest vertical pocket depth we could find on the sonogram, and then created this chart. And I have to say, I was remarkably surprised to see how perfectly linear this chart was. Even greater in terms of surprises was that neither myself nor Dr. Ruth Goldstein had called any case oligohydramnios that had a pocket diameter greater than 2.5 centimeters, and neither Dr. Goldstein nor I ever called a case polyhydramnios that had a pocket diameter less than 7.5 centimeters. So there was almost a perfect correlation with what Dr. Manning had thought was an appropriate means of judging fluid. Now, you'll notice that this is rather broad compared to the other ranges in the graph. But that, of course, is because here you can only be 0 to 2. Here you could be 8. Well, my current record is 22 centimeters. So you could be anywhere from 8 to 22 centimeters in diameter. The last one is the one that is probably most commonly used today, which is the amniotic fluid index. I am not a big fan of the amniotic fluid index. This is a notion, in my opinion, wherein someone says if one measurement is good, then 3, 4, 5, 6, or 7 measurements necessarily must be better. That is not true. Nonetheless, there have been very few measurements I've seen in obstetrical sonography that have taken the obstetrical community by storm, more so than the amniotic fluid index. It's almost like it was chiseled on stone tablets next to a burning bush. Well, let's look at the amniotic fluid index. As you probably are fully aware, since you, I'm sure, do this measurement, there is a range of normal. Now, I happen to use 5 to 24 centimeters for normalcy, with oligo being less than 5 centimeters and poly being greater than 24 centimeters. But there are all kinds of notions as to what the upper and lower limits are. There are also graphs that allow you to do it by date. Again, there's no conceivable way that anything I say now will stunt the use of amniotic fluid index. As you know, what the amniotic fluid index does is exactly the same thing as Manning proposed to measure the deepest vertical pocket, but instead of simply measuring the deepest vertical pocket, you measure the deepest vertical pocket in 4 quadrants of the gravid uterus. Now, what are some of the reasons I don't like the amniotic fluid index? Okay, you know what the rules are. You measure the deepest vertical pocket in an AP dimension without cord or small parts in the 4 quadrants. Add them together. That's the amniotic fluid index. I can follow those rules absolutely precisely by measuring the deepest vertical pocket right there, then move over to here and measure it again, then move over to here and measure it again, then move over to here and measure it again. I have followed every rule of measuring the amniotic fluid index, and it's totally ludicrous. Now, the thing that really bothers me about it is that while you may never have thought of it quite that way, intuitively, every sonographer understands that that doesn't make any sense whatsoever. To basically measure the same pocket 4 times 2 millimeters apart. It's ridiculous. And the knowing of how ludicrous that is drives all the measurements out to the periphery, which is no more logical than measuring them all right here. So, a word to the wise is sufficient. Don't be a slave to the notions that you must go out to the edges of those 4 quadrants to measure the deepest vertical pocket. Now, as I said, I'm a big visual estimator of fluid. Again, the need to measure a pocket diameter or an amniotic fluid index, in my opinion, should be very, very unusual. Only when your visual estimate says, I don't think this is a normal amount of amniotic fluid. If it's a normal amount of amniotic fluid, the amniotic fluid index, or the deepest vertical pocket, should always be normal. Okay, so what do I use as my visual clues for dead center normal amniotic fluid volume? Okay, visual clue number 1 is that the torso of the fetus fills the amniotic cavity from front to back, and there are communicating pockets of fluid between the small parts. It does not require that there be fluid at the back of the fetus, as we see here. I do not require the fetal head to fill the cavity from front to back, but I prefer to see that the fetal head also fills the cavity from front to back. And again, communicating pockets of fluid between the small parts. I will buy you the biggest latte at Starbucks if you can ever find a case that meets these visual criteria, that has an abnormal deepest vertical pocket or amniotic fluid index. So this never requires measurement, in my opinion. Now, those were special large field of view images, but you can do this with a curved array scanner. You can do it with side-by-side linear scans. All you really need is to put together a picture which shows you that the torso fills the cavity from front to back, and there are communicating pockets of fluid between the small parts. That's it. Now, the AFI is certainly not as accurate as the literature suggests. I want you to be cautious when you're thinking about AFIs, because here are 4 measurements, all of which are clearly different, and only one of which is correct. But I absolutely assure you that these measurements will be done by differing sonographers at any one of those 4 points. So those are significant judgmental errors in measurement. But in this case, no measurement is really necessary. This is normal fluid. Torso fills the cavity, communicating pockets between the small parts. That's normal. I want to further caution you about the effect of the urinary bladder on sonographic detection of polyhydramnios. Now, you've been warned about an overfilled urinary bladder in many respects, closing down an open cervix, making a cervix appear longer than it truly is, making something look like a placenta previa when it isn't a placenta previa. Yes, there are many reasons why you do not want an overly distended urinary bladder when you are conducting an obstetrical sonogram in the 2nd or 3rd trimester of pregnancy. But you may not have thought about this. As the bladder distends, it pushes the anterior and posterior walls of the lower uterus together, which squeezes the amniotic fluid into the upper portion of the uterus. Now, water is a non-compressible liquid, so the uterus must accommodate that by increasing its diameters. And among the diameters that increase is the AP diameter. So an overly distended urinary bladder will influence all sonographic estimates of amniotic fluid, the largest pocket diameter, the amniotic fluid index, and even visual assessment, because the thing that we're looking at is the greatest anterior-posterior dimension. Now, the last caution that I will give you is to never turn off the main computer bank. What do I mean by that? There is a terrible tendency to take a number that looks normal and use that, okay? Or to just use numbers instead of thinking your way through a case. Don't do that. You have all of this training and all of this knowledge, and don't throw all that away because there's a number on a piece of paper that says, hey, forget about it. That number's abnormal or normal. Now, I've given you a while to see this screen, and I hope all of you are saying to yourself, now that's a case of polyhydramnios we can all agree with. Great, if that's what you thought, because, in fact, this is a case of profound oligohydramnios. You will notice that the fetal head, these small parts, are all excluded from the fluid that you see here. Every last drop of that fluid is in this fetus's abdomen, and we'll call it a bladder, but it's actually a cloaca. So this is a case of profound oligohydramnios that might fool somebody who's just going to measure this pocket diameter into thinking it's a case of polyhydramnios. Here's another somewhat similar case where if you measure the pocket diameter, you'd say, oh, polyhydramnios. But in fact, all of this fluid is inside of the fetus. Absolutely none of it is in the amniotic cavity. And the reason it got there is because this urinary bladder overdistended and ruptured right at that point, producing a massive amount of urine ascites. So none of this is amniotic fluid. Virtually all of it is urine ascites, and this is also a case of profound oligohydramnios. Another problem with polyhydramnios is that it produces what are called side lobe or grating lobe artifacts, which can make examination of the fetus all that much more difficult. And there are a variety of little tricks that usually your equipment manufacturer can teach you to help eliminate those types of things when you are dealing in this large fluid environment. One of the things that I do is to place a small color Doppler box, which changes the character of the beam. And you'll see as soon as the Doppler color box turns on, the artifact disappears. Artifact, color Doppler box, disappears. In the real world of pregnancies, amniotic fluid increases in volume until about 34, 35, maybe 36 weeks, and then decreases. At 34 weeks, the amniotic fluid volume equals about 1,000 cc's with a range of 500 to 1,500 cc's. That's where the 1,500 cc upper limit of normal comes from. So I've sort of graphed this out here so you can see how fluid is going to increase to about 1,000 cc's and then begin to decrease somewhere around the 34th week of pregnancy. And if it gets to be over 1,500 cc's or under 200 cc's, then it's going to be oligohydramnios or over polyhydramnios. Now, this may be a bit of a surprise to realize that amniotic fluid increases to the 34th or 35th week, because visually on a sonogram it looks to us like amniotic fluid volume is its greatest at around 25 weeks of pregnancy. The reason for that is that our eye is an absolutely abysmal measurer, but it is absolutely fantastic at seeing relativity. At 25 weeks, there's about 500 cc's of amniotic fluid. The fetus weighs about 500 grams, so there's 500 cc's of fetus, and your eye sees a one-to-one relationship between solid and liquid. At 34 weeks, despite the fact that the volume of amniotic fluid is now twice as large as it is at 25 weeks, at 34 weeks, the fetus is going to weigh around 2,500 grams, or is going to occupy about 2,500 cc's. So your eye sees 2,500 cc's of fetus and only 1,000 cc's of fluid. So the solid to liquid ratio is 2.5 to 1, and you erroneously think of that as indicating that the volume went down when in fact the volume doubled. If you go into the literature, you can be overwhelmed by etiologic factors that cause polyhydramnios. So this slide is meant to simplify it as much as possible. There are 5 well-established causes of polyhydramnios, and then the 6th most common cause, possibly the most common cause, is I don't know, and I never figure it out. Anomalies, macrosomia, and twins are the fetal causes of macrosomia, and diabetes and Rh isoimmunization are the maternal causes. Now, these are really the purview of the obstetrician. These are the purview of the sonologist. Let's return to Chamberlain's study. Remember, Chamberlain and Manning looked at a lot of fetuses. They looked at well over 7,000 fetuses. 243 had polyhydramnios, and they compared the gross perinatal mortality per 1,000 fetuses in those two groups. And whoa, look at that. Significantly higher perinatal mortality in cases of polyhydramnios. But they went a step further, and they calculated what is called the corrected perinatal mortality. What is that? Well, if the cause of the polyhydramnios was anencephaly or type 2 osteogenesis imperfecta, or alobar holoprosencephaly, all of those fetuses will die. There's no hope. Those are fatal anomalies. So the obstetrician can't save that fetus. So those are taken out of both. And you can see there were fatal anomalies among the fetuses with normal fluid as well. But the effect was much greater in cases of anomalies associated with polyhydramnios. So the way I look at it is that polyhydramnios approximately doubles the risk of perinatal mortality once you exclude the severe anomalies that can be associated with polyhydramnios. The next important thing to realize is that macrosomia, and I'm not talking about macrosomia from diabetics necessarily, although it doesn't matter what the cause of the macrosomia was. Macrosomia is the most common fetal cause of polyhydramnios. So anomalies and macrosomia are the two leading causes of fetal reasons why you get polyhydramnios. So you can see here that if the fluid was increased, macrosomia was present in many more. If the fluid was normal, it was exactly where you would expect it to be. After all, macrosomia is defined as 10% of the population of fetal weights for gestational age. If you're 90th centile or above, you're macrosomic. Now, we had to subtract these out, so you would expect that 9% would be just about right in this group, so perfectly reasonable. The other thing you need to take away from this slide, though, is if you're waiting to see polyhydramnios as an indicator that macrosomia is the correct diagnosis, you're going to miss the vast majority of cases of macrosomia. So macrosomia is a weight of 90th percentile or more, weight for gestational age, and that is something that I consider a hard rule. Okay, I'm a hard liner on macrosomia and intrauterine growth restriction. If a fetus is in the 90th centile or above, my report will say macrosomia. Doesn't have to have polyhydramnios, but macrosomia causes a lot of cases of polyhydramnios. If you look at diabetes, for example, in Chamberlain's data, again, there's a lot more fetuses of diabetic mothers in the increased amniotic fluid group as a percent. Okay, clearly the vast majority of women with diabetes, their fetuses have perfectly normal amount of fluid, but percentage-wise, you can see the difference. Now, I consider this somewhat misleading because diabetes is also associated with macrosomia and fetal anomalies, and my preference is to separate rather than lump them together under diabetes. Now, I don't have to tell you, I'm sure you're fully aware of the fact that polyhydramnios is associated with an increased incidence of fetal anomalies. This is, in fact, the carrot and the stick of polyhydramnios. We all know increased incidence of fetal anomalies. So you see a case of polyhydramnios, you examine very carefully looking for fetal anomalies, and then you think to yourself, gosh, I sure wish I'd have paid a lot more attention during that lecture by Philly, because when the study is abnormal, your level of confidence is much higher than when the study is normal. You may not think of yourself as capable of excluding fetal anomalies, but I can assure you, you're more capable than you think. Now, here's the real carrot. It's been estimated that half of all anomalous fetuses would manifest increased amniotic fluid volume if all anomalous fetuses proceeded through pregnancies without interventions of any kind. Wow. We're always looking for reasons to find cases of anomalous fetuses. States like California spend millions of dollars a year trying to find fetuses with myelomeningoceles. Myelomeningoceles occur in 1 in 1,600 pregnancies. But here we have a feature which could point the way to half of all anomalous fetuses. Phenomenal. But the problem is it's associated with many types of anomalies. The broadest spectrum of anomalies that I see under any circumstance as a prenatal diagnostician. So, when we look at this, we find that there are marked differences in the frequency of fetal anomalies in reported series. Reported frequency of anomalies seen sonographically varies from 13% to 80%. When you see papers, two papers, one with this number and the other with this number, you can immediately say one thing with certainty. one of those two papers is definitely wrong, and possibly both of them are definitely wrong. So we felt we understood why such a broad spectrum was seen. So we did this study. I mentioned it to you. We looked at 105 fetuses who met the criterion of an amniotic fluid pocket greater than 8 centimeters, and visually all cases also met my criteria for polyhydramnios. We measured the deepest vertical pocket to the nearest half centimeter, and then we ranked them in 2 centimeter incremental groups. And here was the result. We're looking at pocket sizes starting at 8 centimeters and going up to over 16 centimeters, greater than 16 centimeters. And the percent of anomalies increased progressively all the way up to here. So papers that were originally published on polyhydramnios showing 80% of fetuses showing anomalies had an extremely high threshold for calling polyhydramnios. Those that showed 13% of anomalies had an extremely low threshold for calling polyhydramnios. So again, the lesson to take away here is that anomalies are associated typically with greater degrees of polyhydramnios. So if you have a case around 8.2 centimeter deepest vertical pocket or a AFI of 24.5, the chances that that case actually has an anomaly are pretty slim. But if the deepest vertical pocket is 17 centimeters or the AFI is 45, then the probability that there's an anomaly is extremely high. And if you haven't found it, that's when you should start saying to yourself, I'm in trouble here. So you can see that there is a precipitous fall off near this borderline at around 8 centimeters of deepest vertical pocket. These were the results of the study, and nothing that I have learned since this study has changed my mind one iota. Degree of polyhydramnios correlates directly with the presence of anomalies. The more poly, the more likely the poly is secondary to an anomaly. All pregnancies in this study with a deepest vertical pocket of 16.5 centimeters were anomalous. I now have a case of a 19 centimeter deepest vertical pocket with a normal fetus, but those are the rarities. Once you're up around 17 centimeters of deepest vertical pocket, you can be pretty darn sure something significant and abnormal has gone on with this pregnancy. Anomalous has gone on with this pregnancy. The largest pocket diameter in this study was 20.5 centimeters. That is a whopping amount of polyhydramnios. My current gold medalist, personal gold medalist, is 22 centimeters. And all I can tell you is that a woman with a 22 centimeter deepest vertical pocket, when you see her, your heart goes out, because it's a very extremely uncomfortable thing for her to experience. What were some of the other results? Well, in our study, 82% of the cases were singletons and 18% were twins. But remember, the twins only constitute about 1.3% of the total pregnancy population at any time. So obviously, twins are much more prevalent in the world of polyhydramnios than would be accounted for by their prevalence in the world of pregnant women. So twins are associated with polyhydramnios. This, I think, was the most remarkable findings in our studies. Of sonographically normal fetuses, all survived. So here's a case of polyhydramnios. It's examined by a prenatal diagnostician, but you can make a very credible effort to show that the fetus is normal. And if it is, all of them survived in this study. More importantly, possibly still, is that of the sonographically abnormal fetuses in the singleton pregnancies, only 28% survived. That's a 72% mortality rate. And of the 13 that survived, 8 of them, 62%, required surgery in the neonatal period to correct the abnormality. So, what a remarkable difference. Fetus sonographically normal, great outcomes. Fetus sonographically abnormal, scare the pants off of you outcomes. Of the 38 twin fetuses, half survived, which means that the mortality rate was also half. Of the 19 sets of twins with poly, 17 were abnormal. But among the abnormalities, they were mostly associated with monochorionicity. So there were 12 cases of twin transfusion syndrome and 2 cases of acardiocephaly syndrome, more appropriately today called the TRAP syndrome. Only 3 of the twins had actual structural anomalies of the fetus, anencephaly or gut obstruction. When we looked at the anomalies that were present in the singleton pregnancies, not unsurprisingly, you see that top of the list was gastrointestinal abnormalities. Next, central nervous system abnormalities. These are things that I'm sure you're already familiar with. Non-immune hydrops fetalis, of course, is a grab bag of many different abnormalities, but it is one of the types of abnormality that is highly associated with polyhydramnios. Although it can be oligohydramnios, it can be normal fluid or polyhydramnios. Thoracic abnormalities 9, skeletal abnormalities 8. And you have to say to yourself, why in God's name would a skeletal abnormality have polyhydramnios? And again, I don't have a clue. I really don't know why this is. And believe me, I've thought about this a lot, and I do not know why fetuses with skeletal abnormalities get profound levels of polyhydramnios. Here is a type of abnormality that you may see. This is called Kleeblatt-Schädel or cloverleaf skull deformity. You see the 1, 2, 3 leaves of the cloverleaf. These protrude out laterally. Here you see in the mid-sagittal plane that these fetuses have a very flattened nose and a very protuberant forehead. This particular syndrome turned out to be type 2 Pfeiffer syndrome, but here is what I want to show you is look at these deepest vertical pockets here and look at the AFI, 53. Pretty impressive. So why should this child who basically has a cloverleaf skull deformity have massive polyhydramnios? I don't know, but I do know that when I'm examining a fetus with polyhydramnios, I have to have the broadest sense of what types of abnormalities I'm looking for. Non-immune hydrops fetalis, as I said, there are many, many, many causes of non-immune hydrops fetalis. But one of the features of non-immune hydrops fetalis can be polyhydramnios. So here we certainly see a deepest vertical pocket that has to get our attention. And this is a fetus that has pleural effusions and cystic hygromas. This is a very bad circumstance. So my experience with cystic hygromas, nuchal cystic hygroma, very bad. I'm sure everybody that has experience with those has had a similar bad experience. Central nervous system abnormalities, of course, are well-known causes of polyhydramnios. In the era when anencephaly was not diagnosed prenatally, about half of the cases associated with polyhydramnios of fetal anomalous causes were caused by anencephaly. Of course, now that number has dwindled remarkably because alpha-fetoprotein testing is going to find virtually every case of anencephaly. So if the mother undergoes that testing, it will be almost certain that it will come back with an elevated level and will be discovered on subsequent sonography. But here we have anencephaly case that got missed and presented late, and of course does have polyhydramnios. And again, gastrointestinal anomalies are the most common cause of polyhydramnios associated anomaly. So you can actually get massive polyhydramnios with GI tract obstructions. So, reasonably impressive. The torso doesn't really fill the amniotic cavity from front to back. And again, it doesn't take a prenatal diagnostician to realize there's an awful lot of dilated loops of bowel inside of the fetus's belly. This is a case of GI tract obstruction with polyhydramnios. Now, I can't go through anomaly after anomaly, but I would like to deal with one of the more common things that people are confronted with and talk about how I work my way through that to show you that this is actually a relatively complicated but eminently logical means of how we approach certain types of cases in the prenatal diagnostic world. So here's a case with polyhydramnios. We look inside the fetal abdomen, and right there should be the stomach, and I don't see it. So when we see polyhydramnios with absent stomach, whenever I ask the resident, what do you think it is? They always say the same thing: esophageal atresia with tracheoesophageal fistula. Okay, let's take a look at that now. When I see a case of polyhydramnios and an empty stomach or small stomach, my first thought is the stomach is somewhere else, not empty. And where is it going to be? It's going to be up in the fetus's chest. So this will be a congenital diaphragmatic hernia with the stomach not where we anticipate seeing, but up in the thorax. Next, I consider a central nervous system malformation because this can interfere with swallowing, so the stomach will be small and there will be polyhydramnios. But central nervous system malformations are going to be far more common than esophageal atresia with tracheoesophageal fistula. Now here we have another case of polyhydramnios, and very easily seen is this encephalocele off the occiput of the fetal skull. Now, again, I'm not saying this, I'm just saying that polyhydramnios, I've long since given up trying to figure out why fetuses have polyhydramnios. I just want to find out, are they normal or abnormal? If they're normal, phenomenal outcomes. If they're abnormal, horrible outcomes. So, are the swallowing nerves in that occipital encephalocele? I highly doubt it. Here we see polyhydramnios again, and we have a central nervous system anomaly, myelomeningocele. In fact, this is a low lumbosacral myelomeningocele. Now, I can tell you one thing with absolute certainty. The swallowing nerves are not in there. So I'm not so interested in whether the central nervous system anomaly causes abnormal swallowing. What I know is that central nervous system anomalies and polyhydramnios go together. So I'm going to look at the central nervous system from top to bottom when I'm examining a case of Polyhydramnios. Next, I think about cleft lip and palate. You know that up in the nursery, if a new baby has a bad cleft lip and a bad cleft palate, they are fed with a larger than average nipple so that the bolus of milk goes all the way to the back of the throat into the oropharynx. Because otherwise, if they just drink it at the lip level, it will go through the cleft palate and back out the nose, and they won't be nourished. So the same thing happens to the fetus that's trying to drink the amniotic fluid. It just goes through the hard palate and out the nose, so it doesn't get to the stomach, so the stomach is small. It doesn't get to the small intestine, so there's polyhydramnios. Now, cleft hard palate is more difficult to diagnose than cleft lip, but cleft hard palate and cleft lip are almost always associated with one another. So the thing to look for is the cleft lip. That's your best chance of finding it. And in addition, as you know, the AIUM ACR ACOG guidelines require you to take this view of the lip, which will help you to identify it. Now, these are the kinds of severe clefting that result in polyhydramnios because, again, as the child tries to swallow and take a bolus of water to the back of the throat, it simply doesn't work. Next on my list is the hypokinesia syndromes, but I actually look for these first, okay? What are these hypokinesia syndromes? These are syndromes that affect the musculature of the fetus, and therefore they may have abnormal swallowing in addition to other things that can happen. Now, sometimes these fetuses have a look, so already you can sort of see that there's a rather prominent lordosis. That's because these muscles are contracted. But even more importantly, we see that this wrist is held in this, and arm are held in this very abnormal position. I assure you, you cannot get your hand into that position. So immediately on seeing a hand in that position, you can be confident that you are dealing with a case of a hypokinesia syndrome. This is sometimes called the policeman's tip sign. Unfortunately, most often, fetuses with hypokinesia syndromes simply are lying in what is called the fetal position, with the arms folded across the chest and the legs crisscrossed. Now, the difference between this fetus in the fetal position and a normal fetus in the fetal position is that this fetus never moves out of the fetal position. So, as I said, I start first thinking about hypokinesia syndromes. I look at what position the fetus is in. I see that it's in the fetal position, so that's perfectly normal. Then I go on and I'll look at the central nervous system. And then I come back and look at the arms to see if the fetus has moved out of the fetal position, extended its arm, extended its leg. If it does any of those things, it doesn't have a hypokinesia syndrome. Then I look for cleft lip and palate. Then I come back and look for hypokinesia syndrome. If the fetus still hasn't moved, then I bring the fetus back 24 hours later and re-examine it. And if it still hasn't moved, then I will make a diagnosis of one of these hypokinesia syndromes. Pina-Shokir is usually the most common one in our neighborhood, at least. It isn't until I have considered all of these that I am finally coming down to esophageal atresia with tracheoesophageal fistula. And if I'm there, I have to realize that this is associated with trisomy 18 and the Vactorel syndrome. As you know, the Vactorel syndrome is vertebral anomalies, anal atresia, cardiac anomalies. TE stands for the tracheoesophageal fistula, R for renal, and L for limb. when I'm actually diagnosing esophageal atresia, I realize that overwhelmingly that is a presumptive diagnosis. Polyhydramnios and an empty stomach, it's a presumptive diagnosis. And the only way to make the diagnosis with certainty, at least that I'm aware of, is to look up into the neck and the thorax, looking for the dilated esophageal pouch. Here's the heart. The blood vessel coming out of the dead center is the aorta. It's going up toward the arch. Here's the trachea, and sitting behind the trachea is where the esophagus lives, and we can see this dilated esophageal pouch. Now, I don't have the patience to wait around, hoping that I'll see the fetus try to imbibe some liquid and that will dilate the esophageal pouch. So most of the time when I suggest a diagnosis of esophageal atresia with tracheoesophageal fistula or esophageal atresia without tracheoesophageal fistula, I am going to make the diagnosis based on seeing polyhydramnios and a persistently empty fetal stomach. Why am I so cautious? Because I realize that even with those findings, empty stomach and a dilated, empty or small stomach and polyhydramnios, I'm still not going to do all that well diagnostically. So we looked at the relationship of esophageal atresia to amniotic fluid. If if the volume of amniotic fluid was decreased, none of the fetuses had esophageal atresia with tracheoesophageal fistula. They simply didn't have any water to drink. That's why their stomach was empty. If the fluid was normal, fewer than 1 in 10 actually had esophageal atresia. If there was poly and an empty or small stomach, still less than a third had esophageal atresia with tracheoesophageal fistula. So I've got everything I want. Persistently empty or small stomach with increased fluid, and yet my diagnostic accuracy is not very good. In fact, of all of the cases of esophageal atresia that had prenatal sonograms during the time frame of this study that were treated at our hospital, we only detected 42% of them. So we detect less than half of them, and when we have the findings we want to find, we are still going to be wrong in the majority of instances. So it is always a presumptive diagnosis unless you can see a dilated esophageal pouch in the chest or neck, and that it means that overwhelmingly it is going to be a presumptive diagnosis. So when we look at esophageal atresia with tracheoesophageal fistula, of the fetuses with small or absent stomach and polyhydramnios, esophageal atresia with tracheoesophageal fistula was present in less than a third, and when it was present, it was strongly associated with trisomy 18. So in fact, if you think that's the diagnosis, I highly recommend that you consider an amniocentesis to look for trisomy 18. And in addition, I think you want to be very careful to look for the features of the Vactorel syndrome. Another important thing, because we brought up this issue of trisomy 18, is chromosomal anomalies. Well, certainly there were 7 out of the 105 chromosomal anomalies in our group. Now, that's of those patients that actually underwent a karyotype analysis, that was 24%. So that's quite a significant risk. But this was the important thing. Each of these fetuses demonstrated sonographic anomalies. In the 22 fetuses that had a normal karyotype, each fetus was morphologically normal by sonography. When we looked at diabetes, only 5 diabetic mothers were seen in the study cohort, and each had an anomalous fetus. So diabetes in and of itself did not contribute a single fetus to the cohort of polyhydramniotic fetuses. We are also a center for referral of Rh immunized pregnancies, and in our study cohort, there were no instances of Rh isoimmunization alone. If there was, we didn't have any cases of immune hydrops fetalis, but immune hydrops fetalis can be associated with polyhydramnios in the same way that non-immune hydrops fetalis can be associated with polyhydramnios. There were 4 macrosomic fetuses in the group, but none happened to be the offspring of a diabetic mother. So, these are the conclusions that I have when I think about a case of polyhydramnios. The probability of an anomaly is directly proportional to the degree of polyhydramnios. So if I'm looking at a 16, 17, 18 centimeter deepest vertical pocket and I'm not seeing any abnormalities in the fetus, I'm sweating bullets. Diabetes and Rh isoimmunization are not significant contributors to our pregnancies with polyhydramnios. So in fact, if the requisition says diabetes or Rh isoimmunization, I'm not going to be lulled by that information. I'm going to redouble my efforts to check out the fetus to make sure I'm not missing an anomaly, and I am not simply going to ascribe polyhydramnios to either diabetes or Rh isoimmunization. The probability of a normal outcome is high when the fetus is sonographically normal. A karyotype abnormality is unlikely in the presence of a normal sonogram. Now, I would never dissuade a woman from getting an amnio despite the fact that the fetus appears normal. I'm just saying that in our experience, it is very, very, very unlikely to produce an abnormal result. Monochorionic and gastrointestinal anomalies are the most common categories of abnormalities producing polyhydramnios, and they also produce the most severe cases. My gold medalist with the 22 centimeter pocket had twin transfusion syndrome. The overall survival in our study cohort was only 58%, but it was 100% when the sonogram is normal. So, in my opinion, this is one of the greatest strengths of sonography. If the sonogram in a case of polyhydramnios is normal, it remarkably changes the prognosis for the pregnancy. This is extremely valuable. Thank you very much.